Welcome to The Why in Psychiatry,
Hi, this is Dr. Mayo, CEO Fellow,
where we delve into the intricate nuances of psychiatric topics.
My name is Dr. Chandora, attending psychiatrist. I did my residency from University of Connecticut, and then I did my fellowship from Georgetown University in consultation and liaison.
Each episode features interview-style discussions that explore the intersection of the mind, medicine, and the human experience. Together, we'll uncover the hidden why and the groundbreaking discovery shaping the psychiatric landscape. So grab a seat, a warm beverage, tune in, and let's embark on this journey to unlock the mysteries of the human psyche. Only on The Why in Psychiatry.
All right, welcome back to the Why in Psychiatry. Today, we're going to be continuing our series in depression in the special population, and today we'll be focusing on liver disease. I'm your host, Dr. Mayo, consultant liaison fellow, and I have my co-host.
Hi, I'm Dr. Hendwara.
I don't know about you guys, but when I was going through medical school, one of the things that I completely ignored was pharmacokinetics. All that CYP stuff just did not vibe well with me. And so today, I'm going back to school to learn about liver function and why in psychiatry do we have to care about the liver. So, Dr. Andre, I want to learn about the brain. Why do I need to concern myself with the liver?
So, liver is a very important organ in psychiatry, right? This is something that a lot of people ignore, but we cannot ignore it. It's right there in front of your face every time you prescribe a medication, right? Because majority of our medications, with few exceptions, are metabolized by the liver. Once they are metabolized by the liver, they're either converted into an active metabolite or an inactive, and then they go through a process of conjugation, making it more water-soluble and excreted out. So whenever we prescribe a medication that is metabolized by the liver, we need to actually check the baseline liver function, right? AST, ALT, bilirubin, right? So you can order a CMP and you can get all these values. Plus also look at things like albumin, PTINR, and platelets, especially the patient is cirrhotic, right? Because this gives you a lot of information about what is going on and what's a safer treatment in this particular patient population.
Do you do that for all your patients to get a baseline liver function, or just if they give you some hints?
I do baseline liver function on each and every patient to begin with, because some of the psychotropic medications are also hepatotoxic. So if you don't have a baseline liver function, you do not know whether the medication has caused the liver injury or the patient had a baseline liver injury.
That makes sense. Okay.
Like in patients with liver disease, depression is pretty comorbid, right? So the data is like approximately 30 to 40% of the patients with cirrhosis will have comorbid depression. And we need to treat the depression because it also helps with the recovery. For example, when you treat patients who is undergoing liver transplant with antidepressants, the outcome is much better. The acceptance rate of the liver, transplanted liver, is better. And one of the reasons for that is improvement of depression causes an improvement in the compliance with treatment. So because the transplant doesn't end actually just with transplant, right? You have follow-ups and you have to go through rehabs, right? If a patient is depressed, they're not going to do that.
So what you're saying is it's important for us to pay attention to the liver because a lot of our medications are metabolized by the liver. And so it's important to get a baseline liver function before we start pharmacotherapy in these patients. And also, especially in liver disease, there's a lot of comorbid depression, and treating the depression improves patient outcome.
That's right.
What is nitty-gritty about what the liver does with our medications?
So if you look at psychotropic medications, right? So liver plays an important role. So we have a bunch of medication that goes through first pass metabolism.
Okay.
They go through the liver. And as I said, they will either be converted into an inactive metabolite or inactive metabolite, right? So we need to be careful giving medications to patients who have liver damage and medications which goes through first pass metabolism.
Right? What is first pass metabolism?
It's basically the breakdown of the medication. So medication actually goes into the liver and then it goes into the systemic circulation, right? Now imagine patient with cirrhosis where the liver is not working, so there will be something called portosystemic shunting. So anything that enters into the portal system will enter into the systemic circulation without going through the liver. So the shunting can actually be intrinsic inside the liver. It could be outside the liver, or it could be surgical. Especially patients with portal hypertension, you do a shunting.
Yeah.
So anything that goes to the liver, there'll be more of these medications available in the systemic circulation causing toxicity.
Okay.
And we'll talk about those medications.
Okay.
The second thing is plasma proteins. Liver is an important source of plasma protein. And one of the plasma protein to which our medication binds to is albumin. There are other plasma proteins too, right? There's alpha-1 glycoprotein, there are lipoproteins. So in liver disease, especially when patients have cirrhosis, there's not enough albumin produced, right? So if there's not enough albumin, medications which have a very high plasma protein binding will now be available in the free form. And we know that's a free form of the medication, which is active form, right? So we are increasing the concentration of these medications which are highly plasma protein bound. The third thing is the cytochrome P450 system, which we need to know in psychiatry, right? Because we have so many medications which either go through the cytochrome P450 metabolism, and some which blocks it, and some which stimulates it.
Yeah.
So that's called phase 1 metabolism, where cytochrome P450 is involved. So either the medication is broken into inactive form or an active form.
Okay.
And then you have phase 2, where you conjugate the metabolite with glucuronates, sulfate, so that you make it water soluble and excreted. So in liver disease, the phase 2 is not affected. There's a phase 1 that is affected. So anything that is broken by cytochrome P450 will be affected. And the fourth thing we need to pay attention to is patients with cirrhosis will have ascites, right? Because the albumin is low, and albumin is something that keeps the fluid inside a vascular system. So if there's no albumin, fluid goes out of the vascular system into the extravascular space, like your peritoneal cavity, and you also develop pedal edema.
Yeah.
So if the fluid level fluctuates, then it can actually affect the concentration of patients.
And just so the first pass metabolism, different from our phase 1 and phase 2 metabolisms?
So first pass metabolism is basically the medication actually goes through the liver and broken down. So the cytochrome does play a role in that particular process.
Yeah. Okay. I guess the first pass metabolism will be the first touch of the medication. And then in each time around, does the liver continue to work the medication?
So there is something called enterohepatic circulation. So some medication goes through enterohepatic circulation.
Okay.
Yeah.
Now we know how the liver plays a role. So it plays a role through the first pass metabolism. There's also a role with the plasma protein, which is important for toxicity and those medications that bind to plasma proteins, especially albumin. And we know about the phase 1, the cytochrome, and the phase 2, the glucuronidation, and then the importance of fluid overload, which we see in cirrhosis. So I want to get my hands there now. So what medications, specific medications, especially antidepressant for today's episode, goes through these 4 key points that the liver controls?
So the first pass metabolism, let's focus on medication that goes through first pass metabolism. So most of the tricyclic antidepressants will go through first pass metabolism, right? 50% of those medications go through first pass. So you have to be careful with TCAs in patients with cirrhosis.
Okay.
The second medication is SSRI, sertraline, is one of the medication which goes through first pass metabolism. You should be careful with SSRI like sertraline in cirrhosis.
Okay.
Among SNRI, you have venlafaxine. Among the NDRI, you have bupropion. So you have to be careful with all these medications, because if there is cirrhosis and there is porous systemic shunting, you're going to increase the amount of this medication in the system, causing toxicity.
So we need to be aware of this medication in patients with cirrhosis, because their first pass metabolism is dysfunctional because there's the shunting. And so the liver wouldn't clear or process as much as it would in a typical normal liver functioning patient.
Right.
Okay. And then about the plasma protein, what medications?
So as we mentioned, cirrhosis, there's a decrease in the plasma protein production. So there's a decrease in the amount of albumin. So we need to be careful with some of the SSRIs, which has very high plasma protein binding, like fluoxetine. You have to be careful with sertraline, which has very high plasma protein binding. Paroxetine is another one which has plasma protein binding, though actually like paroxetine is much safer in patients with liver disease, right? Then you actually have medications which has very low plasma protein binding, like venlafaxine. But we know that we cannot use venlafaxine because it goes to fast metabolism. Now, let me take it back. I won't say that you cannot use it. You can use it, but you need to be careful, right? You have to use a very low dose and then monitor the patient for any kind of toxicity. Then you have to be careful with duloxetine. The reason you have to be careful with duloxetine is that duloxetine can cause hepatotoxicity.
Yeah.
So that is one of the SNRI that you have to actually be careful with in patients with liver disease. I usually don't use duloxetine in liver disease.
Do we know why it causes hepatotoxicity?
The reason for duloxetine is the hepatotoxicity is especially because of the metabolite, but we don't know exactly what is happening.
Yeah.
Most likely, most of the cause for hepatotoxicity is, we call it as drug-induced liver injury. So you have two different types of drug-induced liver injury. If it happens very early, like in about 1 to 6 weeks, we call that as the immunologic mechanism, right?
Yeah.
You actually have fever, rash, eosinophilia, autoantibodies.
Yeah.
And the second one is actually called as a metabolic or direct liver injury, which usually happens after a latent period of about a month to a year. But it doesn't have any of those hypersensitivity reaction. But we don't still actually understand as to like why duloxetine, but there are case reports of duloxetine causing an increase in the liver function. Yeah.
Okay. An increase in liver enzymes?
Yeah.
So how about the phase 1, the cytochrome? What medications should we be?
So we have a lot of medications which is metabolized by cytochrome P450. Majority of our medications are, and the two cytochrome that plays an important role is cytochrome 2D6, D as in David, and 3A4. And some of the medication antidepressants are converted into active metabolite by cytochrome P450, especially imipramine as well as amitriptyline. Amitriptyline is converted into nortriptyline and imipramine into desipramine, right? So you have to be careful with these medications because you will not actually have an active metabolite, right? You have to be careful also with other medications too, actually, because a lot of our psychiatric medications are converted into a metabolite, right? So phase 1 actually plays an important role. So we usually try to avoid medications which actually goes through extensive phase 1 metabolism.
Does that include amitriptyline and imipramine? Is that
amitriptyline and imipramine are two, and we don't use it that often, but we still, neurologists actually still use amitriptyline for migraine headaches, chronic pain. We use imipramine for nocturnal enuresis.
Yeah.
So you have to be careful because people do use it.
Yeah. And so you're saying if someone has cirrhosis, the phase 1 is not working, is not functioning as well. And so this medication would basically be useless.
You can, the thing is that you can use them as long as you know how to monitor the patient. So always, like in cirrhosis, you always use a very low dose and go very slow on the medication, monitoring these patients.
And like an example, like amitriptyline and imipramine needs that phase 1 metabolism to get to the active function. And so I'm guessing they wouldn't be as effective because they're not getting enough of the active metabolites that is useful.
So they have actually, like imipramine and amitriptyline themselves are actually like
Active.
pretty,
Okay.
and the metabolite itself are actually tricyclic antidepressants.
Yeah. No, triptyline and desmipramine. Is desmipramine?
Desipramine actually is from imipramine. Imipramine is broken down to desipramine.
I thought so. I learned something. Okay. Any other phase 1 medications?
No. There are actually almost all of them are actually broken down, but I would actually say use caution with any medication that has CYP route of metabolism. Start low and go very slow on the medications.
Be concerned about with phase 2, the glucuronidase.
Phase 2 actually is not affected actually in liver disease. It's a conjugation process. So you should be okay with using phase 2 medications. There are very few medications that goes through phase 2.
Your escitalopram, is that a phase 2?
So phase 2 is we have medications like olanzapine actually goes through phase 2. You have got lorazepam, oxazepam, and temazepam. That's why LOT are actually safer in patients with mild to moderate liver disease, not severe and cirrhosis. Because if you give benzo in patients with cirrhosis, you can precipitate hepatic encephalopathy.
Good to know. And then lastly, the fluid overload.
So this is something that people miss, right? Now, the question will be, why are we talking about fluid overload in patients with cirrhosis, right? Yeah. There's one medication that we use to augment the effect of antidepressants, which is called lithium. And lithium is renally excreted. Yeah. So people with cirrhosis can also have hepatorenal syndrome. But the most important thing is their fluid accumulation or overload in the extravascular space. So when you treat patients with cirrhosis, you need to actually take care of their situs. So you do paracentesis, or you actually give the patient diuretics, or you use lactulose to cause diarrhea, so that because if there's constipation, it can actually make hepatic encephalopathy worse. So you have a lot of fluctuation in the fluid, and lithium can be extremely dangerous in cirrhotic patients, though it is actually excreted renally because of this fluctuation in the fluid.
Yeah, that makes sense. That's basically due to the liver diseases, the first pass metabolism, since it's not functioning at a high level in patients with severe liver disease. So medications like sertraline, venlafaxine, TCAs, and bupropion can lead to high toxicity because the liver is not clearing it as much using the first pass metabolism. Medications like fluoxetine and sertraline that has high plasma protein binding, there'll be a higher level of active medication in patients with liver disease. Medications that go through the phase 1, like amitriptyline and imipramine, wouldn't have as much of the active metabolites as you would in a patient without liver disease. But that doesn't mean those medications are not useful, because amitriptyline itself, without the active metabolite nortriptyline, is still useful. It's just things are going to change, and be careful. Go slow and start low. And then lastly, the fluid overload, especially with patients with lithium, due to the fluctuation in fluid with patients with liver disease. Be careful using lithiums in those patients. So now we know all the one is. What medication would you say are relatively safe in patients with?
So there's no safe medication, right? What I would actually recommend is always actually do some literature search.
Okay.
So because when you're prescribing patients to cirrhosis, you need to actually make sure that medical legally you're doing the right thing, as well as you're doing the right thing to the patient, for the patient. Definitely liver, like literature search will be good. But the safer medication in liver disease, right, is medications that are SSRIs. So you have citalopram, you have escitalopram, paroxetine, as well as fluvoxamine, right? So these are safer medications in patients with liver disease. And the medications that I would try to avoid in patients with liver disease, if I have other alternative available, is the medication that you just talked about, actually.
Especially duloxetine.
Yeah, exactly.
Especially duloxetine. Yeah. Okay. And that's, I think, overall, the liver is very important. A lot of our medications go through liver metabolism, especially in patients with dysfunctional liver or patients with cirrhosis. Be careful about these medications that go through the first pass metabolism, medications that have high plasma protein binding, as due to the dysfunction in those, they can lead to high toxicity of these medications. Also be careful for medications that have CYP breakdown, as they might not have the active metabolites that we count on. And then also be careful for the fluid overload if you're going to prescribe lithium as well in these patients. And you can stay more closer to citalopram, paroxetine. Even though paroxetine has that high protein binding, you can still use it. And then fluvoxamine.
The only thing I would add is, if patients actually start a medication and the AST and ALT is more than 3 times the upper limit of the normal, then you taper down the medication and cross-titrate it with something that is safer in patients with liver disease. But do not discontinue, suddenly stop a medication, because patients can go through serotonin withdrawal.
And that is all for today's episode. Thank you.
Thank you.
Thank you for joining us on today's episode. Our tireless team is already hard at work, cobbling together another potpourri of fascinating discussion for next week, so be sure to tune in. Visit our website and our podcast feed and let us know your thoughts on the episode. Subscribe so you don't miss our releases every Wednesday. Until next time, keep smiling, keep shining, and stay curious.